this week on the Back Table Podcast.
I never think of myself as the CEO. It's not that I shy away from hard decisions. It's none of that. It's just, I think it's incredible that I'm given this opportunity to make a difference. And I have a very servant leadership mindset around it. And so then, therefore, when asked how I got here because I made lots of mistakes and I learned from them and people forgave me. I had good people that helped me along the path. I had a great family support. And so it's not so much that I would have done anything differently. I just accept the fact that I've been imperfect, but that imperfection has let me get here.
Welcome to Back Table. I'm Sabeen, and I'm co-hosting here with Aaron, and we have a really special guest on today. You know, we're always looking for top leaders in our field of interventional radiology, and it's my honor to have Dr. Howard Chrisman on the show, who is the president and CEO of Northwestern. And welcome, Howard.
Thank you.
Yeah.
Glad to be here.
Glad to have you on. I did want to share a little story about how Howard and I know each other. I first met Dr. Chrisman in 2006 as a medical student. I had no idea what IR was, but he was my research mentor. Soon later became, a mentor in life, but I was also his chief technical officer. And he hired me for free to go to his house and fix his internet and set up wireless internet. And so along with my buddy, Shankar Rajaswaran, who is also a medical student, we really didn't know what to name his internet, but we knew he was going to do big things. So we called it Dr. Legend. And to this day, I'm pretty sure your wireless internet is still Dr. Legend.
This is true. It is still Dr. Legend. I think when you came, if I went back to 2006, our youngest was 4. And then our oldest now is probably about 8 or so, which means their entire life, they've had the Wi-Fi Dr. Legend. So they've known you their entire lives. Because I have to tell the story every now and then too, but why is it called this? And I have to go through the whole thing and re-explain who you guys are. So
yes, I know. There's been so much that's happened over the last 20 years. I mean, now you're the president and CEO of Northwestern. So tell us, tell the audience a little bit about yourself. Where did you start and how did you end up in the seat that you're in?
Yeah, first of all, thank you for having me. And I will say to the audience, going back to those days, one of my great joys was working with you and Shanks and thinking through how young people choose their course in life. And as you said, I think one was thinking about urology, one was thinking about orthopedics, and we did a few papers together. And I think we presented them at SIR, and it just became a lifelong friendship. And, you'll find, as you get older, the great pride you take in the generation that you helped, sort of the pay forward concept. So I was quite pleased to be able to do this with you. I mean, you know me a bit, but for those that don't, my background, grew up out east in New York. I actually originally thought I was going to become a veterinarian. My dad was a small town veterinarian, so I went to undergraduate school at Cornell to become a veterinarian. And probably my rising sophomore year or junior year, I spent time at Stony Brook University with a cardiologist and really fell in love with the field of human medicine, and sort of that course changed. And when I was in medical school, I actually really enjoyed procedures, and for the first time, and that was early then, about the field of interventional radiology. So I first joined an interventional radiologist in Syracuse when I was in medical school, and then sort of fell in love with the field. That led me to the University of Virginia, where, for those of you that are in IR, Dr. Tegmeyer was sort of one of the country's most foremost interventionalists, Alan Matsumoto, Fritts, really iconic members of the community of interventional. So I fell in love with the field then, had the pleasure of coming to Northwestern, where I trained under Dr. Robert Volgazang and Dr. Al Nemchek and all the people that incredible mentors and that become friends. And during that time period, if people were to ask me, well, how did you end up in this role? Part of it was I wasn't really very good at research. And so I was trying to think through, well, if you're going to have an academic career, is it research? Is it education? What are you going to do that sort of adds to the clinical expertise that I developed? And I had this curiosity around physician leadership and administration, and it led me to get an MBA out actually in Colorado, which was with Jen Durham, who you may not know, but was an interventionalist, and she sort of turned me on to this. And the reason I did that is I was having a hard time understanding what administration was telling me to do. Oftentimes yelling at me, like, why are you doing this or that? And I just couldn't understand the language. And that led to this curiosity, and I just educated myself a little bit, and that education led to just some leadership opportunities. And I'll go back to, again, the Dr. Volgazangs and Nemcheks of the world were just these great mentors and gave me the degrees of freedom to do and explore this, and covered me when they needed to cover me. And I got involved in SIR leadership and learned from that. And over time, I just had a ability to navigate some of this political nuance between administration and physicians, and was able to bridge it. And then I had great people that supported me as I tried different things. And I had Dr. Eric Russell, who was the chairman of the department, who provided pathways in the department to learn and made me the vice chair of finance. And then I had leadership in the health system that asked me to help things. And suddenly one day I was doing this and that, and I woke up and now I'm the CEO. So it was a lot to do with people that cared about me and gave me the opportunity. A little bit was my own sort of grit and determination. And then the last thing I would add is, great support at home. My wife works full time. The kids are busy, but you also, you can't do these things without having the family support. So, without my wife's Amy's support, none of this would have happened. But it's all just came together.
Yeah, there's so many things that I want to unravel. I mean, you talk about your mentors and how you've provided mentorship, how you have this work-life balance. I mean, there's plenty of other IRs who have MBA backgrounds or have learned MBA, and you've kind of touched on it. But I mean, really, what motivated you more than anything compared to other people that you know? You were able to make those relationships mend and rise up the ladder, per se.
Yeah, I don't know if it's as much as motivation, because I think a lot of people are motivated. I think, a couple of things that I would reflect upon that sort of went in my direction. One, and I said this earlier, it's just great people that cared about me, right? Senior leadership that was willing to step aside and give me a chance. And I can't mention too often Drs. Volgazang and Nemchek and Russell, right? These were senior, iconic people. I'm a 30-something kid. They're known across the country, and they're like, just giving me these opportunities to present nationally, to go on committees. So some of it was being around really good, caring people that sort of opened some doors for me. Part of what I think you have to have is deep self-awareness, around what you're capable of doing, what skill sets you have, be able to empathetically listen to different viewpoints. And I do find a lot of times physicians can have pretty strong opinion, and sometimes those opinions can come across to others as a potentially not inclusive, maybe condescending, not sort of engaging. And if you're going to get ideas and have diverse opinions, and you're going to work through coming to the best decision, you have to be able to listen. Not all physicians are great listeners. And so, if you're not willing to listen a bit, if you're not willing to acknowledge, the other thing that I did is, and it's sort of what you're not willing to acknowledge, I'm not the smartest guy in the room. Right? Like, I'm just not, right? There are lots of people that are way smarter than me in different areas. And so you hear it all the time, be around people that are smarter than you, and that breeds success. I was completely comfortable with that. I mean, Sabeen, the people were around, right? Like, and I'm not the smartest person in my own house, right? So, I mean, but what I do know is, like, I can get myself around those people, and so I can bring them in and make them feel very much part of the decision making. So I think some of it is there's lots of MD MBAs out there, but if you're going to sort of use your skill sets both as a physician and as a leader, you have to have the awareness around what you're capable of doing and what you're not capable of doing, and engage people. And it's not unique to just physician leadership in general. I think you do pretty well if you include people and know your limitations.
Totally. I mean, you've always been a really good person to make relationships. I mean, you made me feel comfortable, even though I was a medical student in this field that I had no idea about. And even though I contaminated your field multiple times when I first scrubbed in.
That's true, by the way, Aaron. That is true.
You didn't scream at him?
No,
he told me I could always go into a non-procedural field.
There's always pathways for people that don't have.
That's right.
I scratched my face
skills
after doing it before doing the uterine embo. I will never forget that. And then grabbed the light. No, so going back kind of your IR background, profound. And something that I sometimes have trouble with is how do you now become unbiased? I mean, you can't really, in your role now, you are overseeing the entire organization. How do you deal with your innate desire of IR and balancing that with all other fields?
Yeah, I mean, I think we all bring biases to everything, right? And it's healthy. I think the difference that I try to execute on is I'm aware of that bias. And so I try to either remove myself from those equations, right? It's just like this conflict of interest concept, right? Like, look, if we're going to decide to debate between adding, 2 new IR suites or 2 new cardiac, like I'm going to let others weigh in unless I really think they're going down a direction that's not in the best interest of the healthcare system. I try to put myself out of the equation of some of those things. Having said that, I do think thoughtful bias is okay, right? I mean, I do think the field of interventional radiology has proven itself, right? How do we know it's proven itself? Because every other specialty is doing it, right? Thoracic surgery, nephrology, cardiology, which has been around for obviously a long time, vascular surgery, neurosurgery, right? This idea of image-guided therapy and the Seldinger techniques and guide wires and catheters. When we were younger, Sabeen, these turf issues and these debate and these, well, that's not the gold standard and you guys aren't clinicians and all this stuff, the noise we grew up with. All that's gone by the wayside because people understand the power of what was discovered in IR. So where I use my biases, it's, we know interventionalists and people like us are creative, are curious, are finding solutions. And so I can apply those broadly. But if it's really like a true IR issue where, you have to decide yes or no, I try to have a wonderful leadership team. I have a spectacular COO. I have a spectacular CFO, the chairman of the department here, Dr. Carr, who's also trained as an interventionalist, was a fellow of ours, is terrific. So I let them to really make some of those decisions that might be seen as too biased, but holistically, there's nothing wrong with acknowledging interventionalists are really innovative in what they do and they're problem solvers. And I think taking that part of the equation and applying it more broadly is okay.
Yeah. Another kind of question, and then I'll let Aaron have some time too, is that there's always that, and I've always wanted to ask you this, and now I can just ask you it publicly, is physicians are always like, I hate admin.
Yeah.
Admin is crazy. They're not on our side.
Yeah.
You being on both sides now, tell me more light into that issue and how can we make things better?
I think you have to come, and I said this a little bit earlier, why do I think I'm successful? You have to put yourself in this other person's seat, position, and think about how they're perceiving the environment, what they're trying to accomplish. And everyone that chooses to go in healthcare, maybe that's a little bit dramatic, but most people that choose to go in healthcare, regardless of whether they're a physician or another type of individual contributing, wants to make people's lives better, right? They're not there because there's 1,000 different fields someone in administration could go to. And we have the most talented administrators here in the country, right? Really capable people, well-trained, strong backgrounds. They could go into any number of different fields that have different economic outcomes for them that are not perhaps as mission and purpose driven. So if you take a moment to say we're all trying to do the same thing, right? We're trying to change and transform the lives of the patients we care for. They have a lens, they have something that they're bringing to the table. And that's what, when you ask me, why do I think I've been in part successful, is not early in my career, because trust me, early in my career, I learned from the mistakes I made because I was that person, right? I was the same person you're referring to. But once I learned to sort of think through their position, through their eyes, it helps you then gather that input. And so it becomes less confrontational, right? There's a reason we look to plan over 5 years. There's a reason revenue cycle management is important. There's a reason costs are important, right? All these things lead to higher performance. And you have to perform in all quarters, right? You have to have incredible quality outcomes. You have to do things that are part of discovery, but you have to be economically sound in what you do, as you can't afford those other things. You have to plan for things that can occur that are not necessarily right in front of you, like they are in the procedure room. You have to think about, what does marketing mean? You have to think about these things. And as a physician, most of us don't have the skill set that they have. So to me, it's like, you need teammates. And so if you look at them as teammates, right? If you ask, it's not just Sabeen that's my teammate, it's the collective. You do so much better. And I think when physicians believe they're the only one playing the game and they don't acknowledge everyone in the room, and they don't acknowledge administration that's made this all possible, then you're going to fall short and you're going to have that tension. I had this great conversation. I won't name the department because I don't want to get in trouble, but I'm sitting in we built this beautiful new tower, and I'm sitting with a group of strongly opinionated physicians who were bemoaning a lack of investment in this department. And literally, this building was built for this department. And I said to them, okay, let's step back for a second. This room you're in, this building you're in was designed for you. How is that not an investment? By the way, this building is about $600 million. So sometimes you know, it's like, who's on your team? And it's really everyone. And every now and then calling out this behavior and say, guys, gals, whatever, come on. Like, we're here for you. Like, we're working with you. And for me, it's a little easier, right? Because literally yesterday, you know, I'm in Scrubs doing a UFE. It's the last thing that Riyadh and Krish let me do. I'm down to one technical procedure I'm allowed to do. That's it, fibroids. But they also see me, right? I get it, right? So it's a little bit easier for me.
You know, coming from my point of view now, you as a CEO of Northwestern, Aaron Fritts started Backtable, is a CEO of Backtable. Is like, there's a lot of leadership qualities that people need to drive a successful business. And I think at Backtable, we've done a lot. And so I know Aaron has a lot of questions, really kind of just to see how leaders thrive.
Well, Sabeen, you already did a great job. You actually answered a lot of my questions already, Howard. And it's funny, I was pre-vet as well as an undergrad until I got a job. I worked in a dog kennel for a summer, and I had so many close dog bites that I was like, I don't think this is right for me. And then I got a job in a human hospital, and I was like, oh, I can, this actually works. And then I discovered IR, and the rest is history. But yeah, Howard, I mean, first off, shout out to Frank Ficini for recommending you come on the show, because you have this unique background and unique trajectory. And I think Frank really just wanted to kind of get your story out there to help inspire all these other, you know, IRs that are kind of struggling in not just academic situations, but private practice. That I can speak from my experience, and Sabeen, you probably share this. It's just like IR is so niche in these community hospitals that it's sometimes really hard to get people to listen to you, because some departments don't even interact with IR. And from what I've heard from IRs in the community, they're really struggling with like getting their voices heard, getting their foot in the door to make these decisions on capital equipment and, you know, workflows and those sorts of things. Do you have any advice for the docs that are out in the community? I'm sure you've talked with a lot of people, not just in academics, but in the community about this, about kind of, you know, where to start in building trust with their admin and with their peers in other departments.
Yeah, I think you landed on the exact right word is trust, right? It's really first building the trust. I mean, it gets back to a little bit of taking the time to introduce yourself, meeting with the appropriate leadership, right? It's do you take the time to sit and meet with the hospital president and introduce yourself and get to know each other? Do you meet the appropriate leadership and decision makers to share your stories and what you're trying to do? Are you able to actually show a value proposition? You know, if you're going to build trust and you're going to advance the value to the organization, you have to be able to show it a bit. And so how do you really show that so that you are really seen as part of what makes this community hospital impactful for the community? I mean, the mission of these hospitals is to change the health of their community. And so how do you tell that story, whatever it might be, you know, whether it's a pre-surgical abscess drain that you need to put in, something relatively simple, to more advanced procedures so patients don't have to leave the hospital, right? Another big thing is by sort of articulating the types of things you do that prevent patients from going out of the hospital or leaving their neighborhoods, having to go to an academic medical center. I mean, Sabeen's a great example of this, right? Like the capability that you have in an interventionist like Sabeen is every bit capable of what we do here. And so when you have someone like that in your environment, the hospitals become so appreciative that they're willing to listen. But I think it really does begin to that. How do you build just a relationship and trust? And some of this is common sense. Do you have a dinner with them? Do you do something social with them? You know, do you invite them to the IR area to show them what you're doing? Do you have others that will be a champion for you? So if you have other clinical colleagues that are respected, can they help you tell that story? It's not just out of the hospital or leaving their neighbor. It's having to go to an academic medical center. I mean, underneath it all, and I really do think what originally built the success of IR, at least here at Northwestern, is we never said no. Not that we weren't thoughtful about when we were saying yes, but if it's 2 a.m. or 2 p.m. or 5 p.m. or Friday at 6, right? With all due respect to our other colleagues, it was more common that other surgical people were leaving at Friday at 3 and then asking us to do their case that they would normally have done. And so some of it's just building that story around being available and building trust.
Yeah, I think that's part of the problem, is overcoming those misconceptions. Like, I remember when I first came out, cardiology colleagues were like, well, multiple times they're like, well, you don't have clinic, so therefore you shouldn't be partaking in this patient's care. And it was like, no, we do. Like, you're spreading misinformation here. Like, that's not true. And so, but you also have to be a team player and not cause a turf war with those same cardiologists. You got to kind of, like you said, develop your champions so that everybody's going to bat for you, because that whole IR against the world attitude, I think, just doesn't work to get these things done. I don't know if you have anything to say about that.
Look, I totally agree. And, I'm of the age where I've lived through all of this, right? I lived through when IR was just a novel, interesting field that was putting these filters in that were relatively new and doing these new types of procedures and renal angioplasties, and it was so novel that there was no turf issues. People were more curious. Then suddenly the facts started to show that we could do things as good or better with less intervention, and suddenly people started to feel threatened, and both audiences people can't see me, but sort of curled their fists like this, and so both audiences, the vascular surgeons, the cardiologists, whomever, started to sort of, rather than embrace collaboration, became more antagonistic. And then I think you started to see, more individuals that would try to figure out, okay, this infighting is just not good for anyone. So how do we work together? And you started to see cardiology and vascular surgery and IR starting to work together. Then I think you started to see us each figure out, what is it that we just do well? And now you've seen this primary certificate and how we, how our whole specialty has evolved to much more of a clinically oriented, more decisive, and at least here, those turf issues are essentially gone. They just people have figured out what you're good at and what you can do. And we do a lot of IO and we do a lot less renals, and the world is sort of stabilized. And like literally I said to someone the other day, we really don't have, at least here, real turf issues anymore. Everyone's landed. And the other part of this is, again, it gets back to self-awareness. There are really good interventional cardiologists and really good interventional vascular surgeons and really good, for a while they were like, well, you don't know anything clinical. And we were like, well, you can't do anything with a catheter. Truth was in between. So I have no patience for those turf wars anymore. And where they exist, it's usually not in the best interest of patients.
Oh, 100%. 100%. On that same vein, looking ahead, I mean, we just talked about the kind of the history of IR, but where do you see the specialty going in the next 5 to 10 years with everything that you've seen?
I think that's an interesting question. Stepping back a little bit, because as CEO, I think about this broadly. I have said to our workforce, to our board, and Sabeen's always been ahead of me on this stuff, but technology and what technology is bringing, the obvious capabilities of AI, we're going to see healthcare that's going to look so different. So my daughter's doing a residency. When she graduates in 4 or 5 years, the world's going to look massively different. So unlike you and I, look, there's been change in this past decade and there's been neat discoveries, but I just think what we're seeing unfold before us and where we're going to go is going to be incredible for both clinicians and for our consumer, for our patients, right? Their knowledge base and what they're going to be able to understand is going to be so much more capable. And so we have to be so much more capable. I do think the field of radiology, diagnostic radiology, is going to have dramatic change. It may not happen now. I gave the RSNA, I think Matt Morrow was the president then, I gave a presentation about the future. And I think we should embrace AI, whether you want to call it artificial intelligence or augment. I think we need to embrace it. But I believe it's foolish to imagine it's not going to massively transform the diagnostic radiology workforce. And I think you're going to see a change. I think radiologists will be more capable, more likely to be able to be impactful beyond just a simple diagnosis if we embrace the data, but it's going to look different. For interventional radiologists, the impact may not be as dramatic as quickly because there is a procedural component to it. There's your eyes and hands that I don't think will be readily replaced by robotic interventions as it might be in other areas. But I do think what we're going to see is increasingly just more data and more capability to do things with better outcomes as we sort of adopt AI tools and we can think through whether it's a technical or just decision making. And I also think we're going to catch things earlier, so we'll start to intervene earlier with certain opportunities to help treat and cure patients because we'll identify things earlier than we ever would have before by some of this augmented capability. So I think IR will change. I think in part it will change because we've always been leaders in this, right? Radiology has been the great discoverers of, where it goes back to Röntgen, right? And then you look at what IR has done. So I think we'll take a lead in a lot of this. And I think most of the benefit's going to really be in adopting where AI can fit into our workflow to make us more capable around decision making. And then if it can guide us better, we'll end up in a better place.
Yeah, I mean, I'm glad that you brought that up about AI, and I'm interested in being CEO and president. Is that a general shared opinion about other CEOs through other hospital systems that they're all embracing AI? Do you guys meet common conventions and talk about different hospital stuff? Or how does that all work?
Two questions.
I know.
So in general, and you guys know this as well as I do, almost every CEO in every industry is asking the question every day about AI. Like it is ubiquitous. It's everywhere. And I think at the same time, you're also asking, well, how do you thoughtfully do it, right? Because there are ethical considerations. There's all these potential impacts, negative impacts that could occur with too broad an adoption. So the answer is yes. Every healthcare CEO, whether it's on the clinical side or administrative side, because realize you can revenue cycle management, marketing, communications, it's both sides, it's everything. So even when people ask me now they want another full-time equivalent or FTE, I'm like, can a tool do this, right? Like my communication teams want more people. Don't tell them I'm saying this, but I'm like, I can just go to ChatGPT and boom, right? Like here's my speech. I'll nuance it to me, but so to answer your first question, yes, there is, I think, wide acceptance and excitement with a little anxiousness around AI. And one of my beliefs, if I'm going to be seen as a CEO that made a difference in the evolution of Northwestern medicine, is because we're going to lead in this space. I would say we're probably in the middle, but I think we're going to try to aggressively lead. And the other part of that is you have to have partners in this because you're not going to be able to run as fast as these companies. So we're working very closely with Tempus, which is one of the leaders in the AI space that started with next generation sequencing that's here in Chicago. We're working closely with Epic, right? Epic's starting to integrate this, for some basic functionality. We have a long-term relationship with Microsoft. Siemens Healthineers, right? As you think about the diagnostics. So we're going to work with people to execute in a thoughtful way. Your question around how often do we meet with CEOs, I think there are meetings that occur for people that know me or maybe don't know me. I'm not a big fan of meetings. I'm not a big fan of late night dinners. So there are probably meetings going on that maybe I should be at, but I tend to avoid all those extracurricular activities.
Good for you, man. That's great because that's hard to do.
Yes.
I got one more question and I'm going to let Sabeen finish up. Yeah. Is around, you mentioned early in the recording that you got your MBA, and this comes up a lot amongst, I don't know, kind of my peers. This sort of generation is looking at, should I do an MBA as a physician to do more than just clinical medicine? And so I'm just curious to hear your perspective, given where your MBA led you to, but do you think it's essential for somebody to have that kind of education to do something beyond clinical medicine?
I don't think it's essential in any way. I think it's helpful depending on the circumstance. So the thing that I always tell people, your MD degree, those letters are the ones that always have to come first. And so what I find too often is, and it's a natural sort of self-reflection of individuals, I find too often is like, oh, administrative life is easy. I'm going to get my MBA. I'm going to go into administration. I'll make more money. I don't have to work as hard. And so if the motivation around it isn't pure, which is I really want to begin to think about how I can, in different ways and different stages of my career, impact healthcare going forward, maybe there's a health reason to do it. Maybe there's a life balance reason to do it. So I just want to understand things better. I could take courses, I can read books, I could do lots of different things, and MBA is one of those paths. If the purpose of the MBA is really because you think this world of administration is easier and more lucrative, then you're getting it for the wrong reasons. And I will tell you, I find great peace when I'm in the angio suite. Right? I mean, I really find it comforting. I'm around people that I know well, that care about me, and I don't feel stress around it. I'm not working the hours that Sabeen and others are doing, right? So I don't have that same rhythm. But the administrative environment, certainly in this role, is way more challenging than anything I've ever done. Now, the CEO role in general, as you know, because Aaron, you're in this role in a different way, but like it's a different feel. And I'm not suggesting every MD that's getting an MBA is trying to become a CEO, right? I know that's not the case, but I think it's only worth doing if you really are interested in understanding how business works and you want to understand the language and think that you can make an impact, and it gives you a little more opening of doors. But if it's just because you think life's easier and you make more money and you won't work as hard, it probably would not take that direction.
Well, you also said early on that it's like you needed to learn a new language, right? Because you go to these meetings and you have no, people are talking about VC funding, and it's like lingo that we don't get trained on, and we have no idea what we're talking about, and probably have no business trying to speak the language until we learn it. So I thought that was really important too, and like you said, having the right reasons to do it, because it's not cheap and it's not a small time commitment either.
Yeah, it's not time and money, and as you said, if you go to the right reasons, it's like anything. If you wanted to learn a new skill set, it's worth investing, but you've got to be doing it in my opinion, for the right reasons.
Yeah. Sabeen?
I mean, are you hiring at Northwestern? Because I'd love you to be my CEO. I really hope all CEOs are like you, Howard, because you're doing it for the right reasons, and that's why Northwestern is such a juggernaut. I guess this question, if the answer is no, that's okay, but is there anything you would have done different in your path now? Like, is there anything that you would have changed to where you are right now?
I mean, I might not say no, but I might answer it as if it was a no, right? I mean, I think, I am so blessed to be in the role I'm in. I never think of myself as the CEO. It's not that I shy away from hard decisions. It's none of that. It's just that I think it's incredible that I'm given this opportunity to make a difference. And I have a very servant leadership mindset around it. And so then, therefore, when asked how I got here because I made lots of mistakes and I learned from them and people forgave me. I had good people that helped me along the path. I had a great family support. And so it's not so much that I would have done anything differently. I just accept the fact that I've been imperfect, but that imperfection has let me get here. I had this great, whether we keep this or not, I don't know. I had a friend who's a Rhodes Scholar. And when they interview these young people, these Rhodes Scholar applicants, right, these are the smartest people like you've ever met. I don't know if you know any Rhodes Scholars. They're incredibly gifted people. The interesting part about it is that the chairman of the interview committee can't be a Rhodes Scholar, which is me. I'm not a Rhodes Scholar. So literally they're like, look, find the dumbest person you know so that person can be the chairman. So I'm like, Howard, will you be the chairman? So I'm in a room with like 10 other Rhodes Scholars, right? And again, these people are incredible. And I'm the chairman. And you have these people that come in who are now even smarter than the other Rhodes Scholars, like, because every generation's smarter. And there's this young cadet ranked #1 in West Point, right? So I've always admired the academies, right? These are incredible people that give to our country. And they asked us similar questions of being like, tell us about a time that you've sort of made a regretful mistake. And he goes through and he said, that's not how we look at it, right? So he goes through this early dawn exercise. And essentially he's leading some troops, and this early dawn exercise, basically every member of his troop gets killed, right? And he tells this story and he goes, that resulted in the next time I did this, there were no losses of lives. So he said to me, I know I'm like, this could have been one thing I said I could have regretted, but that's how we learn. So in some ways, this young person taught me, right? Like we are going to make mistakes and they're not going to look back and regret, because without those decisions, I wouldn't be where I was. And I'm blessed to be where I'm at, you know?
Yeah, that's such a great way to look at it, because we're all there, we're all here because of things that we learned from mistakes or not mistakes and everything. And so I think that's a really good note to end on, really. I don't know, Eric. I'm just really happy to have you on, Howard, and I'm happy to have you in my life. Thank you for getting me to where I am, and thanks for always being there as a mentor. And it's like you're paying it forward, I guess, from Vogelsang and Nemchek to you to me, and then you can hire me at Northwestern so you can be my CEO.
Come on. Thanks, Mrs. I know your best friend misses you. So, well, thank you for this opportunity. You guys are doing good work, and as Aaron mentioned, I appreciate Dr. Fraccini sort of giving me this sort of introduction. And as I've said to others, if I can ever help and do anything, just let me know.
Well, thanks, Howard. We're sort of doing a series on IR leadership. Anybody else that stands out that you think we should have on the show?
Well, depending on the generations, there's obviously people like a Matt Morrow and an Alan Matsumoto and a Fritts Engel. You know, Matt had a similar role at UNC. And then there's his next generation, you know, like Ryan Hickey at NYU, I like quite a bit. Super interesting.
Yeah, Ryan.
Section chief there. So no, there's lots of good people. And then, you know, outside of academics, I actually find, and Sabeen knows this, some of the most curious, innovative creators of discovery occur outside the walls of AMC, right? There's just these incredible minds. And then, you know, our European colleagues, like there's a lot going on across the globe. And having that sort of international mindset's interesting. So I think all of us are quite proud of the specialty in which we've grown up. And I think we'll continue to do good things.
Yeah. Well, thank you so much, Howard, for coming on the show. Appreciate your time.
Yeah, thank you. Thank you.
All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a Backtable hoodie in your future. If you have questions or comments, DM us. We're @_BacktableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. Backtable is hosted and produced by myself, Anish Parikh,
and Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.